Welcome to the Deep Dive. We're here to extract the core knowledge from complex topics, helping you master challenging foundations.
And today, we're tackling a really crucial one, pediatric anesthetic management.
Right. It's a field that demands so much more than just, well, shrinking down adult techniques.
Absolutely. Our goal today is to really get into the fundamental differences, the physiology, the anatomy, the pharmacology that define these young patients.
Because safe practice hinges entirely on understanding those distinctions, doesn't it?
Yeah.
Especially for the youngest ones.
Exactly. Misunderstand the basics, everything else falls apart.
So, defining the pediatric patient isn't simple. They're constantly changing.
It's a spectrum,
Mhm.
and we use these categories really as clinical reference points based on key developmental stages.
Okay, let's lay those out. Where do we start?
We start with neonates. That's from birth up to the first month of life, a period of just massive, rapid adaptation.
We got it. Birth to 1 month.
And become the infants from 1 month up to 1 year. This is where you see some of the most dramatic physiological shifts.
Like the fluid compartments we'll get into.
Precisely. And protein synthesis, metabolism, a lot happens in that first year.
After infants.
Toddlers, ages 1 to 3, often brings unique behavioral challenges into the mix, for the preoperative period.
Then 4 to 6 years.
That's the preschool group, followed by school age, roughly 6 to 13 years.
And finally, we get to adolescence.
Right, 13 up to about 18. And they can be complex too, maybe some lingering physiological immaturity, but also adult-like body types and, importantly, psychological needs.
It's clear why this stratification is so vital. Getting the category wrong could mess up dosing right from the start.
It's the absolute bedrock. Every calculation flows from that initial assessment.
Okay, let's dive into those foundational differences then. Section 2, starting with body composition. You mentioned fluid content.
Yeah, this is where the difference is just staggering. It's all about total body water, TBW, and how much of it is outside the cells in the extracellular fluid, or ECF.
So how different are we talking?
Think about this. A preterm newborn can be up to 90% water. And critically, half of their body weight, 50%, is ECF.
Wow, 50%, just extracellular fluid.
It's huge. A full-term baby is still around 80% TBW, 40% ECF. Compare that to an adult.
Where it's about 60% TBW and only 20% ECF, right?
Exactly. And the key takeaway, the clinical nugget here, is that this massive shift, this decrease in TBW and relative ECF, happens really intensely during that first year.
So by about 12 months, they're much closer to adult ratios.
They are. It's a very rapid change early on.
Okay, so this massive, mostly extracellular fluid volume, what does that actually do to the drugs we give? How does it impact pharmacokinetics?
This directly impacts the volume of distribution, or VED. It's a core concept.
Explain VD for us again, quickly.
VED is basically the theoretical volume a drug would need to dissolve into to achieve the concentration we measure in the blood plasma. So if you have a much larger fluid compartment,
The drug gets diluted more.
precisely, you get this dilutional effect, especially with water-soluble drugs that tend to stay within that ECF space.
Yeah. Like muscle relaxants.
Exactly. Things like rocuronium, pancuronium, some antibiotics, they're largely stuck in the ECF. So to get the desired plasma concentration, you actually need a larger loading dose per kilogram in infants compared to adults.
Okay, larger dose for water-soluble drugs. What about lipid-soluble ones, like fentanyl? They behave differently.
They do. Infants have less fat and muscle tissue compared to adults. So while a lipid-soluble drug might initially get diluted a bit, there aren't as many tissue sinks for it to redistribute into.
Meaning it stays in the plasma longer.
Well, it can lead to higher peak plasma concentrations if you just use standard weight-based dosing. And because their clearance is also slow, which we'll get to, the effects can be prolonged. You need real caution.
So it's this constant balancing act, adjusting up for one drug, down for another. It sounds complex.
It is, and it gets even more complicated when you factor in protein binding.
Right, because not all the drug in the plasma is active. It has to be free.
Correct. Plasma proteins bind drugs. Albumin mainly grabs acidic drugs, while alpha-1 acid glycoprotein, or AG, binds basic drugs.
And AG handles many of our common anesthetic agents.
Yes, local anesthetics, opioids. Many basic drugs bind to AG.
But in infants and neonates, protein levels are lower.
Both the total amount of protein is lower and the binding capacity isn't fully mature. AG levels are only about 50% of adult levels at birth.
50%, and when does that catch up?
AG approaches adult levels around 5 to 6 months. Albumin takes a bit longer, maybe closer to a year.
So less binding means more free active drug floating around. Shouldn't that make the drug effect much stronger?
Logically, yes. A higher free fraction should mean a bigger punch. But here's the clinical reality. The immaturity of their metabolic system, their clearance, often plays a much bigger role.
How so?
Even if more drug is free initially, if the body simply can't get rid of it efficiently, the drug hangs around much, much longer. That prolonged duration due to slow clearance usually outweighs the effect of the increased free fraction from lower protein binding.
So the inability to clear the drug is often the more dangerous factor.
In most clinical scenarios with anesthetics in the very young, yes. Reduced clearance is the dominant concern.
Okay, let's talk about that clearance engine then. Metabolism and excretion. The goal is to make drugs water-soluble so the kidneys can remove them.
That's the basic idea. Metabolism generally happens in two phases. Phase R reactions, oxidation reduction, hydrolysis, mostly run by the cytochrome P450 system, the CYP450 enzymes. They sort of prepare the drug.
In phase 2.
Phase 2 is conjugation. The body sticks an endogenous molecule onto the drug like glucuronic acid or sulfate, making it much more water-soluble for excretion.
And where's the big bottleneck at birth?
Phase 2 reactions are significantly immature. The enzymes are there, but their activity level is way down.
Like the classic example of jaundice.
Exactly. That's due to decreased glucuronal transferase activity. The newborn liver just can't efficiently conjugate bilirubin, so the unconjugated form builds up.
And this immature phase 2 system directly impacts drug clearance times.
Dramatically, you see hugely prolonged elimination half-lives for many drugs.
Can you give some examples? How long are we talking?
It's pretty shocking. Bupivacaine, a common local anesthetic, can have a half-life of around 25 hours in a neonate.
25 hours, compared to just a few hours in an adult.
Right. Or take diazepam, a benzodiazepine. Its half-life can be up to 100 hours in a neonate.
100 hours? So giving repeat doses based on adult schedules would be disastrous.
Absolutely guarantees toxic accumulation. You have to understand these timelines.
What about other routes, like oral or rectal, often used for pre-meds? How does the immature gut affect oral absorption?
Generally, it's slower in neonates and young infants. Gastric emptying takes longer, doesn't reach adult speed until about 6 months. Stomach pH is also a bit variable, initially more acidic, which might favor absorption of acidic drugs.
And rectal administration seems like it can be really variable. Why is that?
It's all about the venous drainage anatomy down there. You've got 3 main veins. The superior rectal vein drains into the portal system.
Meaning it goes straight to the liver for first-pass metabolism.
Correct. So a drug absorbed there gets heavily metabolized before it even reaches the rest of the body. But the middle and inferior rectal veins drain directly into the systemic circulation.
Bypassing the liver initially.
Exactly. So if you give a drug like midazolam or an opioid, which are subject to first-pass metabolism, you have to place it in the lower part of the rectum.
To hit those middle and inferior veins.
Yes. If you put it too high, you lose a huge, unpredictable amount of the drug effect. You get erratic results.
Okay, that makes sense. Before we leave metabolism, we absolutely have to talk about acetaminophen. It's so common, but the toxicity profile is a perfect example of these metabolic issues.
It really is. Most acetaminophen is metabolized safely through phase 2 conjugation, glucuronidation, and sulfation. That handles about 80%.
But a small amount goes down a different path.
Yes, a small fraction goes through phase 1 via CYP450 enzymes. This creates a highly reactive, toxic intermediate metabolite, NAPQI specifically.
But normally, the body deals with that toxic intermediate.
It does. Normally, it's quickly detoxified by conjugation with glutathione. But the problem comes with high doses, or even just repeated doses close together in very young children.
Their glutathione stores run out.
Exactly. The immature liver has limited ability to regenerate glutathione, especially if the child is stressed or sick. Once glutathione is depleted, that toxic NAPQI intermediate builds up, binds to liver cells, and causes irreversible damage, hepatocyte injury, necrosis.
Which is why sticking to the correct pediatric dosing and intervals is so absolutely critical.
Non-negotiable. The margin for error is very narrow.
Okay, that detail really underscores the risks. Let's shift to Section 3, specialized anesthetic agents. Inhalation agents first. Why is induction so much faster in babies?
It comes down to how quickly the anesthetic gas concentration builds up in their lungs, in the alveoli, the FA. 2 main things accelerate this, both tied to their higher metabolic rate.
Okay, what are they?
First, they have much greater minute ventilation. They just breathe faster and move more air per minute relative to their size. Second, they have a higher ratio of tidal volume. the amount of air per breath, to their functional residual capacity, the FRC, which is the air left in the lungs after breathing out.
What's that ratio difference?
It's about 5 to 1 in infants, compared to maybe 1.5 to 1 in adults.
So each breath washes out a much larger proportion of the existing lung gas and replaces it with the anesthetic mixture.
Exactly. That rapidly drives up the alveolar concentration, FA, towards the inspired concentration, FI. The FA-FI ratio rises quickly, meaning the brain concentration follows suit very fast.
But you mentioned this is a double-edged sword. Faster induction is good, but
But that rapid rise in concentration, combined with the fact that a higher percentage of their cardiac output goes to vital organs like the brain and heart, leads to exaggerated myocardial depression.
their hearts are more sensitive.
Yes, the immature heart muscle itself is less compliant, less contractile. It just doesn't have the reserve to compensate hemodynamically when hit with a high concentration volatile anesthetic.
So speed comes with a significant risk of cardiovascular instability.
A very significant risk. Careful titration is paramount.
Let's quantify the dose needed using minimum alveolar concentration, or MAC. How does MAC vary in kids? Is there a pattern?
There is, but one agent is famously different, this sevoflurane anomaly.
Okay, what's the usual pattern first?
For most agents, like isoflurane or desflurane, MAC tends to increase from the newborn period, peaking around 6 months of age, and then it gradually decreases towards adult levels.
So 6-month-olds need the highest concentration, relatively.
Generally, yes. But sevoflurane flips that.
How so?
With sevoflurane, the MAC is actually highest in the youngest infants, those under 6 months, sometimes up to 3.0% needed in pure oxygen, and then it decreases after 6 months.
That's completely reversed. Why? Any theories?
The leading ideas involve the differential maturation of inhibitory pathways in the central nervous system, maybe GABA receptor changes, possibly hormonal influences. It seems the infant brain's sensitivity to sevoflurane matures on a different timeline than its sensitivity to other agents.
If a young infant needs, say, 3% sevoflurane, that's a high dose. How does that square with the risk of myocardial depression we just talked about? You can't just crank it up, right?
Absolutely not. Even though sevoflurane has a low blood gas solubility, meaning you can change the concentration quickly, you must titrate it very cautiously. You have to constantly watch the hemodynamics, balance the need for adequate depth against that risk of hypotension.
Okay, let's look at the specific agents. Sevoflurane is often the go-to for mask induction.
It is, primarily because it's non-irritant, not pungent. Kids tolerate breathing it much better than, say, isoflurane. Plus, that low solubility means rapid induction and, importantly, rapid emergence later.
Any downsides? What about fluoride ions?
It does get metabolized and produces fluoride ions, and you can measure elevated serum levels. But years of evidence show these levels aren't high enough to cause clinically significant kidney damage. It's considered very safe from that perspective.
Now contrast that with isoflurane.
Isoflurane is pungent, an airway irritant. Mask inductions can be stormy coughing, breath holding, and hemodynamically, it causes dose-dependent drops in heart rate and blood pressure in infants.
Why the heart rate drops specifically? Adults often get a reflex tachycardia.
Infants lack that mature sympathetic reflex. Their baroreceptor response isn't fully developed, so when isoflurane causes vasodilation and drops blood pressure, they don't compensate with an increased heart rate. The pressure just falls.
A direct hit with no safety net. What about desflurane? It's the fastest.
It has the lowest blood gas partition coefficient, 0.42. So yes, fastest onset, fastest offset, fastest changes in depth. Great for rapid wake-ups. It's also pungent. And if you increase the concentration too quickly, it causes significant sympathetic stimulation, tachycardia, hypertension. You have to ease it on slowly.
The outline mentioned it might be superior for obese pediatric patients. That seems counterintuitive if it causes sympathetic stimulation.
A benefit there is actually related to its rapid washout. In obese patients, volatile agents tend to accumulate in fat tissue, prolonging emergence. Because desflurane is so insoluble, less dissolves in fat and it clears much faster regardless of body fat.
Leading to quicker recovery of airway reflexes.
Exactly. Studies suggest faster return of swallowing and gag reflexes compared to sevoflurane in obese kids, which is a big safety advantage for preventing complications during emergence.
Okay. And nitrous oxide, its main trick is the second gas effect.
That's its primary clinical benefit in this context. Its low solubility means it's rapidly taken up by the blood during induction. As that large volume of N2O leaves the alveoli, it effectively concentrates the remaining volatile agent, the second gas.
Speeding up its uptake.
Right, accelerating the induction. And the reverse happens on emergence. The rapid washout of N2O helps pull the volatile agent out faster too.
Now we have to address a really sensitive topic, the developing brain controversy, the potential long-term effects of anesthesia.
Yes, this is a major area of research and concern. We have substantial animal data, mostly rodent and primate studies, showing that exposure to common anesthetic agents early in life can cause structural changes, like increased neuron cell death, apoptosis, and later functional deficits.
But that's animal data. How does it translate to humans?
That's the crucial question and where it gets murky. Proving causation in humans is incredibly difficult. Epidemiological studies have looked for associations between early anesthetic exposure and later neurodevelopmental issues, like learning disabilities or ADHD.
And the results?
They're largely inconclusive or conflicting. It's extremely hard to separate the potential effect of the anesthetic itself from the effects of the underlying illness that required the surgery, the stress of the surgery, prematurity, other environmental factors. There are too many confounders.
So what's the current thinking? Is there an association?
The consensus is that general anesthesia in early childhood may be associated with some long-term subtle decreases in areas like language and cognition, but the evidence isn't strong enough to prove it's the anesthesia causing it, and the magnitude of any potential effect seems small.
Is there a recommended safe age to wait for elective surgery?
No, there's no definitive age threshold identified. And critically, we have to weigh this potential uncertain risk against the known, definite risks of not doing the surgery.
The risk of delaying necessary treatment.
Exactly. Untreated pain, prolonged illness, delaying correction of significant defects. These things are known to be harmful to the developing nervous system. In most cases, the immediate benefit of the surgery outweighs the theoretical long-term risk of the anesthetic.
That's a really important perspective. Okay, let's switch to IV agents. We know they hit the brain fast, but their effects last longer in kids.
Generally, yes, due to that slower metabolism and renal excretion we discussed. Plus, the blood-brain barrier is more permeable in infants, allowing more drug into the central nervous system.
Propofol is the main IV induction agent. Dosing needs to be higher.
Yes, again, because of that larger volume of distribution for the initial dose, infants often need 2.5 to 3 milligrams per kilogram for induction, which is higher than adults on a per kilo basis.
But it still carries risks.
Oh, absolutely. Significant risk of hypotension due to myocardial depression and vasodilation. You have to be ready for that.
And we must discuss propofol infusion syndrome, PIS. This is seen with prolonged high-dose use.
Correct. PIS is a rare but potentially fatal complication, usually seen in critically ill children receiving propofol infusions for sedation, typically for longer than 48 hours, and at doses above 4 milligrams per kilogram per hour.
What's the underlying mechanism? It's metabolic.
It's thought to involve mitochondrial dysfunction. Propofol, at high concentrations, seems to inhibit the respiratory chain and uncouple oxidative phosphorylation. Basically, it stops the cells from using oxygen efficiently to make energy.
Forcing them into anaerobic metabolism.
Yes, leading to a cascade of problems. Severe lactic acidosis, muscle breakdown, rhabdomyolysis, high triglycerides, heart failure, and often cardiovascular collapse. It's devastating. Particular caution is needed in kids with known or suspected mitochondrial disease.
What about etomidate, used for unstable patients?
Its main advantage is cardiovascular stability. It tends to maintain blood pressure and systemic vascular resistance, making it useful in kids with congenital heart disease or shock.
But it has a significant drawback.
Yes, adrenal suppression. Even a single induction dose can temporarily inhibit cortisol production, which can be a major problem in critically ill patients who need that stress response. Its use is generally limited because of this.
And ketamine, often seen as cardiovascularly supportive.
It usually is because it causes catecholamine release, which supports heart rate and blood pressure. It also preserves respiratory drive, which is useful. It provides dissociative anesthesia.
If there's a warning attached.
A critical one. Ketamine itself is actually a direct myocardial depressant. Its supportive effects rely on the patient having adequate stores of their own catecholamines, like adrenaline, to release.
So if the patient is already depleted from chronic illness or severe shock,
then that direct depressant effect can unmask itself, and you can get paradoxical cardiovascular collapse.
Yeah.
You have to be very careful using it in sick, catecholamine-depleted children.
Okay, let's turn to neuromuscular blocking agents, the muscle relaxants. These are water-soluble, right?
They are largely confined to the ECF, so again, larger volume of distribution in infants, meaning a larger initial dose might be needed per kilo.
But there's also a difference in sensitivity related to the receptors.
Yes, a pharmacodynamic difference.
Mm.
Neonates have the fetal version of the acetylcholine receptor at the neuromuscular junction, which contains a gamma subunit. This gets replaced by the adult epsilon subunit over the first couple of months.
And the fetal form is more sensitive.
It's more sensitive to non-depolarizing relaxants like rocuronium or vecuronium. They require a lower plasma concentration to achieve blockade.
So, more sensitive, but larger VD. How does that play out clinically for dosing?
It means the initial dose might be similar to or slightly larger than adults on a per kilo basis to fill the VD, but because they are more sensitive and clear the drugs more slowly, the dosing interval needs to be longer. You need to wait longer between doses to avoid accumulation.
What about succinylcholine, the depolarizing agent? Its use is very restricted now.
Extremely restricted in pediatrics by the FDA, primarily due to the risk of triggering massive, life-threatening hyperkalemia and cardiac arrest in children with undiagnosed muscular dystrophies, particularly Duchenne's.
So it's only for emergencies.
Yes, essentially limited to true airway emergencies, like refractory laryngospasm or maybe a critical rapid sequence induction if absolutely necessary, and only if the risks of not using it are deemed higher. It's also absolutely contraindicated in malignant hyperthermia susceptibility.
Okay, so for the non-depolarizers, how do we reverse the blockade at the end?
Typically with an anticholinesterase, like neostigmine, usually dosed around 50 to 60 micrograms per kilogram. And you always give it with an anticholinergic atropine or glycopyrrolate to counteract the muscarinic side effects, especially bradycardia.
What about sugammadex?
Sugammadex is a game changer for reversing rocuronium and vecuronium specifically. It works incredibly fast. While it's not officially FDA approved for under 18s yet, pediatric studies show it's well tolerated and effective. It's becoming a key tool, especially in difficult airway situations where rapid reversal is needed.
How do you know when reversal is adequate in a baby or young child who can't follow commands like lift your head?
We rely on clinical signs. Can they flex their arms? Can they lift their legs and bring their thighs up toward their abdomen? Those indicate reasonable motor recovery. For neonates, we can measure negative inspiratory force, or NIF.
NIF. What's the target value?
A NIF of at least negative 32 centimeters of water pressure generally correlates well with adequate respiratory muscle strength for safe extubation.
That brings us neatly to Section 4, preoperative assessment and airway management. The initial interaction seems crucial here.
It really is. You're gathering vital medical information, but you're also building trust with anxious parents. Their insights are often invaluable how the child normally behaves, any subtle symptoms they've noticed.
What are some key things to screen for?
Always ask about heart murmurs could indicate a septal defect, meaning you must be meticulous about avoiding air bubbles in IV lines. Recent colds or URIs obviously flags an irritable airway. History of steroid use raises concern for adrenal insufficiency. You tailor the plan based on these findings.
And fasting status, the classic 2-4-6-8 rule.
Standard ASA guidelines. 2 hours for clear liquids, 4 hours for breast milk, 6 hours for formula, non-human milk, or a light meal, and 8 hours for heavier or fatty meals.
Why is sticking to this so important, beyond aspiration risk?
Prolonged fasting, especially in infants and preemies, poses a real risk of hypovolemia and, critically, hypoglycemia. Their glycogen stores are limited.
What about the newer ERAs protocols using carbohydrate drinks before surgery? Do they count as clear fluids under the 2-hour rule?
That's a really important point. No, they don't. While these carb tanks can be beneficial, they have solutes and take longer to empty from the stomach, usually around 3 to 3.5 hours. So they should generally follow the 6-hour rule, not the 2-hour rule for clears.
Good distinction. Okay, managing upper respiratory infections, URIs, this comes up constantly. When do you postpone surgery?
First, you try to differentiate. Is it chronic allergies with just clear runny nose? That might be okay. Or is it an acute infection, thick, purulent discharge, fever, maybe a wet cough? That's concerning.
What's the actual increased risk if you proceed with an active infection?
Significantly increased airway reactivity. Laryngospasm risk goes up maybe 5-fold, bronchospasm risk 10-fold, especially if the lower airway is involved and you're using an endotracheal tube.
So clear signs of severe infection mean postpone.
Yes. Fever over 38 Celsius, wheezing, productive cough, those generally warrant postponing elective cases. The usual recommendation is to wait 4 to 6 weeks after the infection fully resolves.
Let's talk pre-medication for anxiety. Midazolam is still common.
It is. Oral or intranasal midazolam works well for anxiolysis in amnesia, short-acting.
But non-pharmacologic methods are gaining ground.
Definitely. Things like letting kids use interactive tablets or handheld games in the pre-op area have been shown in some studies to be as effective or even more effective than midazolam at reducing anxiety. Plus, no drug means faster discharge readiness later.
What about having parents present during induction?
The evidence on whether it's better than pre-medication is mixed. It can help some kids, maybe increase anxiety in others, or the parents themselves. If parents are present, you absolutely have to prepare them for what they'll see, the excitement stage, involuntary movements, changes in breathing patterns so they don't panic.
Airway equipment. Why do we generally use circle systems now instead of older Mapleson circuits?
Circle systems use a CO2 absorbent, like soda lime. This means you can use lower fresh gas flows, which conserves expensive anesthetic gases and, importantly for kids, helps retain heat and humidity in the breathing circuit. Mapleson circuits rely purely on high fresh gas flow, like 2 to 3 times the minute ventilation to flush out CO2, which is inefficient and dries out the airway.
Okay. Endotracheal tube sizing. There's been a shift in understanding the anatomy.
Yes. The old teaching was that the cricoid cartilage was the narrowest point in a child's airway, hence the preference for uncuffed tubes to avoid pressure injury there. But modern imaging suggests the airway is more cylindrical, like in adults, and the narrowest point is often actually at the vocal cords, the glottis.
But we still use age-based formulas as a starting point.
We do. For an uncuffed tube, a common formula is age in years plus 16 divided by 4 gives you the internal diameter in millimeters. For cuff tubes, which are used much more now, it's often age in years 4 plus 4.
These are just guides, though. How do you confirm the fit is right?
The gold standard is the leak test. After intubation, you close the pop-off valve and listen over the neck while inflating the lungs. You want to hear an audible air leak at a specific pressure range.
What's the target pressure?
Usually between 15 and 30 centimeters of water peak inspiratory pressure. Too tight, no leak below 30, risks mucosal damage. Too loose, leaking at low pressures, makes ventilation difficult.
What about the laryngeal mask airway, the LMA? When is that used?
For many cases where intubation isn't needed, especially shorter procedures with low aspiration risk, they come in sizes all the way down to size 1 for infants under 5 kilos.
Any specific precautions with LMAs?
Cuff pressure is key. You should check it after placement and periodically, aiming for around 15 to 25 centimeter H2O, especially if using nitrous oxide, because N2O can diffuse into the cuff and overinflate it, potentially causing nerve injury or ischemia.
Okay, now for the really critical airway complications. Laryngospasm first. What triggers it?
It's a powerful reflex closure of the vocal cords, mediated by the superior laryngeal nerve, often triggered by secretions, blood, or airway manipulation, especially during light anesthesia. Risk is massively increased with a URI or exposure to secondhand smoke.
Management depends on whether it's partial or complete obstruction.
Yes. If it's incomplete, you hear stridor, see paradoxical chest movement, the first steps are: stop the stimulus, deepen the anesthesia, propofol or more volatile, apply positive pressure ventilation with 100% oxygen, and perform a strong jaw thrust. Often, gentle PPV will break it.
But if it progresses to complete obstruction, silence, no air movement.
That's an emergency. You need immediate pharmacological intervention. Atropine first to prevent bradycardia from hypoxia or succinylcholine, then succinylcholine, usually IV but IM, 4 mg choline if you don't have access.
Is there a non-drug maneuver to try?
Yes, the laryngospasm notch technique. Apply firm inward and upward pressure with your fingers just behind the earlobes at the base of the mastoid process. It's thought to stimulate nerves that can sometimes break the spasm or elicit a sigh. Worth trying while getting drugs ready.
And bronchospasm, that's constriction lower down.
Right, smooth muscle constriction in the bronchioles, increasing airway resistance, much higher risk in kids with asthma or an active URI. The classic sign on the monitor is that upward-sloping, shark-fine appearance of the expiratory capnogram waveform.
Treatment.
Again, immediate action, 100% oxygen, deepen the anesthetic significantly. Volatiles are bronchodilators. Give inhaled beta agonists like albuterol directly down the ETT. If it's severe and refractory, epinephrine is the next step, usually 5-10 millicg kilos subcutaneously, or IV if available.
Okay, deep breath. Let's move to section V, fluid management and homeostasis. This needs careful attention. Starting with maintenance fluids, the 4-2-1 rule.
Yes, based on the Holiday cigar formula. It estimates hourly fluid needs based on weight and metabolic rate. It's 4 millimoles per kilo per hour for the first 10 kilos of body weight.
Okay.
Then 2 millimoles per kilo per hour for the next 10 kilos, from 11 to 20 kilograms.
Got it.
And finally, 1 millimole per kilo per hour for every kilogram over 20 kilograms.
So a 25-kilogram child would get 10 by 4 plus 10 by 2 plus 5 by 1 equals 40 plus 20 plus 5 plus 5 equals 65 millimolars per hour for maintenance.
Exactly. That covers their basic needs. Then we have to account for the fluid deficit from being MPO.
How is that calculated and replaced?
Calculate the deficit simply. Multiply their hourly maintenance rate by the number of hours they were NPO. Then the standard replacement schedule is give half of that calculated deficit in the first hour of anesthesia.
And the other half?
Give the remaining half spread evenly over the second and third hours.
Plus, we need to replace ongoing losses during surgery. Third spacing?
Yes. This depends heavily on the type of surgery. Minimal trauma might only need an extra 3-4 milli-kAh or ER. Major abdominal or thoracic surgery can cause huge fluid shifts, requiring maybe 7-10 milli-kAh or even more of crystalloid replacement on top of maintenance and deficit.
Using balanced salt solutions like LR or Plasmolite.
Correct. Those are generally preferred over straight normal saline in large volumes.
Now, the big shift regarding glucose and IV fluids. Routine dextrose used to be standard. Why not anymore for most healthy kids?
This is a really critical safety change driven by neuroscience. The concern is about neurologic outcomes if the child suffers an ischemic or hypoxic event during anesthesia, like severe hypotension or airway obstruction.
How does glucose worsen things in that situation?
If the brain is starved of oxygen, it switches to anaerobic metabolism. If there's lots of glucose around hyperglycemia, this anaerobic pathway churns out large amounts of lactic acid very quickly.
Leading to worse acidosis in the brain cells.
Exactly. That severe intracellular acidosis significantly worsens neuronal injury and leads to poorer neurological recovery compared to a similar insult in a normal glycemic state.
So avoiding hyperglycemia is brain protective during potential crises.
That's the rationale. We aim for normal glycemia.
Are there exceptions? When do we give dextrose?
Absolutely. We don't want hypoglycemia either. Premature infants, babies under 10 kilograms, infants of diabetic mothers, critically ill children, those on TPN, or undergoing very long surgeries, they are at higher risk of hypoglycemia and do require glucose monitoring and often dextrose-containing fluids, typically D5 or D10 solutions.
Vigilance is key for those groups. Okay, finally, blood management. Estimated blood volume, EBV, varies hugely with age.
Massively.
Yeah.
A previe might have 90-100 millirole kilogram. A term neonate, maybe 80 millirole kilograms. An older child over 6 years, closer to 65-70 millirole kilogram, like an adult.
So a small volume loss in a tiny baby is a huge percentage.
Precisely. That's why calculating the maximum allowable blood loss, or MBL, is so important.
How do we calculate MBL?
The standard formula is MABL equals the estimated blood volume, EBV, times the starting hematocrit minus the target hematocrit, all divided by the starting hematocrit. It gives you a volume threshold for transfusion.
And when replacing blood loss with crystalloid before transfusion, why the 3-to-1 ratio, 3 millimole crystalloid for 1 LML blood loss?
Because crystalloid rapidly equilibrates across the entire extracellular fluid space. Only about 1/3 of the volume you infuse actually stays in the intravascular compartment, the blood vessels. So you need to give 3 times the volume of blood loss just to maintain intravascular volume with crystalloid.
Makes sense. Transfusion triggers, are they different in kids?
Generally, similar principles to adult apply transfuse based on physiology, not just a number. But the threshold might be higher in certain groups. For example, premature infants often need their hematocrit kept higher, maybe above 30%, to optimize oxygen delivery due to immature lungs and heart. A common rule of thumb is that 4 millilograms of packed red blood cells, PRBCs, will raise the hemoglobin by about 1 GDL.
Got it. Okay, final section. Emergence, recovery, and morbidity. Emergence delirium sounds dramatic.
It can be. Postoperative agitation, restlessness, crying, thrashing, incoherence. Quite common, incidence reported anywhere from 10% to 80%. Usually self-limiting, lasts maybe up to 45 minutes.
What's thought to cause it?
A leading theory is that the very rapid emergence we get with low solubility agents like sevoflurane and disflurane might cause a temporary dissociative state. The brain wakes up faster than it can fully orient itself.
Can we prevent it?
Yes, certain drugs given toward the end of the case seem to help. Propofol, fentanyl, and especially dexmedetomidine have shown good prophylactic effects. Interestingly, midazolam doesn't seem to prevent it effectively.
The decision to extubate awake versus deep, how do you choose?
It's based on the patient's risks. History of a difficult airway, risk of aspiration, full stomach, those generally mandate an awake extubation, so you know their airway reflexes are fully back. If the main concern is a very reactive airway, asthma, recent URI, a deep extubation might be chosen to avoid stimulating the airway during emergence, which could trigger laryngospasm or bronchospasm.
Which stage is actually riskier for airway problems induction or emergence?
Statistically, critical airway events happen more frequently during emergence and extubation than during induction and intubation. It's a high-risk period.
There was a meta-analysis comparing deep versus awake extubation outcomes.
Yes, it found, perhaps counterintuitively, that while deep extubation carried a higher risk of upper airway obstruction, like the tongue falling back, it was associated with a lower risk of overall airway complications, combined things like coughing, breath holding, desaturation.
So it's a trade-off based on the specific patient.
Exactly. You weigh the risk of obstruction against the risk of reactivity.
Regional anesthesia is becoming more common in kids.
Hugely so, especially with ultrasound guidance, making peripheral nerve blocks much safer and more precise. It offers excellent pain relief, reducing the need for opioids and their side effects like respiratory depression.
But the unique thing is performing the block after the child is asleep.
That's the standard practice in pediatrics. Trying to do a block on an awake, scared child is usually impossible and unsafe due to movement. While doing it under anesthesia is generally safe, it does mean you can't easily assess for nerve injury symptoms immediately, and recognizing things like an accidental dural puncture with an epidural can be trickier.
Okay, let's look at the bigger picture. Morbidity and mortality data from the POCA registry. Is anesthesia riskier for kids overall?
Generally, yes, the baseline risk is higher than for healthy adults, especially in infants and those with significant comorbidities. The POCA registry data from 1994-2005 really highlighted this.
What were the key findings? Who was most at risk?
Children with pre-existing heart disease, congenital or acquired, had a much higher risk of cardiac arrest during anesthesia, about 50% higher than kids without heart disease in that data set.
And the primary causes of anesthesia-related cardiac arrest?
Respiratory events were the most common trigger, often laryngospasm leading to hypoxia. Cardiovascular causes were next, typically related to hypovolemia or sometimes hyperkalemia from blood transfusions. Medication-related arrests became less common over time, likely due in part to the shift from halothane to sevoflurane.
This whole deep dive really emphasizes the incredible complexity. Pediatric anesthesia is absolutely not just adult anesthesia scaled down.
Not at all. It requires this constant dynamic integration of specialized knowledge, understanding how a drug behaves differently at 6 months versus 6 years, how fluid needs change, how the airway matures. It's a distinct discipline.
You have to master these fundamentals. There's no substitute.
That's the bottom line. Safe, effective care depends entirely on understanding and applying these core physiological and pharmacological principles that are unique to children.
Which brings us to our final thoughts, circling back to that tension between known needs and uncertain risks.
Right. So here's something for you to consider. Given the ongoing uncertainty about the true long-term neurocognitive impact of anesthetic exposure on the developing brain, where we have concerning animal data but inconclusive human evidence, how should we, as clinicians and as a society, ethically balance the undisputed, immediate need to treat serious, painful, or life-threatening conditions in children against these potential, unknown future risks, especially knowing that untreated pain and illness are themselves harmful to neural development? It's a profound challenge we face every day.